Without further ado, I would like to invite Dr. Manjula Rao, consultant, breast specialist, and oncosurgeon at Apollo Proton Cancer Center. She will enlighten us on the topic early detection of breast cancer and diagnosis, and how it affects outcomes for the patients. The time is yours to share your expertise, ma'am.
Thank you, Aishwarya. Namaste and a very good afternoon to one and all. Now, when I'm in conversation with my colleagues in oncology and we usually discuss about patient presentations, their treatment and their outlook, I often find myself silently thanking my lucky stars that I chose the field of breast oncology to specialize in. And do you know why? Because unlike a few of my colleagues, I'm one of the lucky ones who's able to send my patients home after their treatment smiling and with a hope and promise of a beautiful and a functional tomorrow. Do you know why? Do you wonder what I mean? The C word, or cancer, for the longest time when heard, instilled fear in the hearts of people with the reputation for being associated with devastating outcomes. It's supposed to be life-threatening, associated with morbidity, and is looked upon as a possible full stop right in the middle of their life story. But I'm very happy to inform you today that this narrative is not entirely true, especially when we talk of breast cancer. Are you aware that breast cancer can be cured? Do you know that it is associated with very high survival outcomes of more than 90% when detected early? Can you imagine that women today, when diagnosed with breast cancer, they have the option of not just being able to have their lives saved, but also their breasts? Yes, all the above are indeed true, if and if only the cancer is caught in the early stages. Breast cancer is a very ancient disease with so many different treatments and theories that have been described since prehistoric times. However, for the longest time, the treatment of breast cancer has always been very radical, very disfiguring, and associated with a lot of side effects and complications. It meant for the longest time, close to a century, a mandatory breast removal and exposure to toxic chemotherapy with side effects and possibly prolonged radiation. All this leading to various side effects, but no added benefit to the survival of patients. That continued to be a very dismal 25% or less. But fast forward to today, thanks to the research that has been done over the last 3 to 4 decades, we have gotten to know breast cancer a bit better. We've begun to understand that it's the nature of the cancer that governs how the patient is actually going to do, and not how much we remove surgically or not how radical we actually go. So for those patients who present in the early stages, we're not only able to save their breast, but also ensure that it looks similar to the opposite, the unaffected breast, and in some cases even better, by using oncoplastic techniques, and the survival outcomes are unaffected. It is similar to someone who is, who has undergone a mastectomy. So if you visit the American Cancer Society website, you would see a table put up there with data which tells you how the survival worsens with increasing stage of the disease, with the best survival attributed to patients who are in stage 1, and that percentage, that number, is as high as 90%, and even more in those patients where the disease has not moved to the or affected the regional lymph nodes. So now, thanks to advancements in technology and such as we have equipment like digital mammography, we have tomosynthesis, etc., which helps us diagnose the disease even before it can be felt by the patient's hands during screening. And now, if the disease is very small and has not yet spread to the neighboring lymph nodes, there is a chance that such patients can even avoid toxic chemotherapy. Even when it comes to evaluating the lymph nodes in the arm, as is usually done for patients suffering from breast cancer, we can restrict our surgery to a very advanced minimalistic technique called the sentinel lymph node biopsy, which ensures less side effects when compared to axillary clearance. Now, all of these advancements, they help to provide the patient with an improved sense of body image, enhanced psychosocial outcomes, improved survival, and a very superior quality of life. A statistic that I have repeated like a stuck record the whole of this month of October is that while more than 50% of the patients diagnosed with breast cancer in our country present to us in the late or the more advanced stages of the disease, in the West, this number is less than 10%. So when we, in our country, we have the means, the access, the know-how, and the technology required to ensure early diagnosis and treatment initiation with very good outcomes, there is no reason why our statistics should be any different from our Western counterparts, which currently it is. So it's time we take ownership of our health, and we at Apollo are here as always to join hands with you all in this endeavor. Which is why, and this is the reason for today, for why we're all here today, for the launch of the 24-hour breast cancer clinic. So please don't hesitate to visit us if you feel there's something off about your breast health, or if you need any clarification. Remember, a stitch in time saves 9. Thank you.
That was truly insightful, ma'am. Thank you for shedding light on this critical topic. Now, I invite Dr. Usha Mehta, surgical oncologist at Apollo Cancer Center, Chennai. She will shine a spotlight on the significance of familial breast cancer and the pivotal role of breast screening. I invite you to take the stage, ma'am.
Very good afternoon to one and all gathered here for this event today. I'll be presenting a small discussion on familial breast cancer, basically about what it is and what is the importance of screening patients in familial breast cancers. So as we all know, breast cancer is the leading cause of cancers across the world and also in our country, and that it is multifactorial, which means that it has a genetic and a non-genetic cause. So what is familial breast cancer? It's basically the breast cancers that cluster within families with more than one generation affected with breast cancers. Almost 10 to 15% of newly diagnosed breast cancers are familial. What is different between the familial breast cancer and the hereditary breast cancer? So not all patients who present with a family history of breast cancer actually have a hereditary breast cancer. They are two different things. So any patient presenting with a strong family history of breast cancer with an identified defect in a defined gene is called as a hereditary breast cancer. So breast cancers which cluster in families could also be because of other factors like environment and lifestyle exposure. And they could also be genes which are intrinsic within the family which may not be identified and are not relevant to the cause of breast cancers. So as you can see here, only 10% of total breast cancers are familial cancers, 5% attributed to hereditary, and the rest are sporadic. So many people have family history of breast cancer, but only 5 to 10% are hereditary. Most patients who have these genetic mutations are born with it. That means that they have inherited the defective gene from one of their parents. And learning how these, if you are actually carrying this inherited mutation is very important, because these kind of patients need active, additional screening modalities so that their risk is higher of developing breast cancer. And people also have higher chance of developing cancer, and that's why they need more intensive surveillance in terms of mammography and other imaging modalities at a very younger age. So why is it important to determine the risk of developing breast cancer is to make a decision on monitoring policy, to formulate the strategy for screening and for a correct therapeutic approach. So as you can see here, familial breast cancers are attributed to few genetic defects. As we all know, the most common could be the BRCA positivity, which we all must have heard of. So what are the factors that decide the risk of a familial breast cancer? So if more than 3 first-degree relatives, now what a first-degree relative is either a mother, a sibling, or a parent is affected with breast cancer, that history is relevant. Or if you've had more than 2 first-degree relatives and the age at onset is less than 40 years, that is relevant. And if somebody who's had bilateral breast cancers. So if you see in the BRCA, why is BRCA so important is because the lifetime risk of developing breast cancer in these patients is almost 50 to 70%. So these could be the red flags for an individual with a family history pattern of breast cancer where more than one relative is affected, more than one organ is affected, male breast cancers, and cancers in both or one organ. So ideally, the risk assessment should be performed at the age of 30 by a healthcare professional. And whenever the lifetime risk of a breast cancer development is more than 20% based on the models that we utilize clinically, these patients are considered at high risk. So what is the need for screening patients with familial breast cancer because they belong to a high-risk category? It requires an early detection and diagnosis with early commencement of therapy with favorable outcomes and improved survival. It also needs additional screening modalities for better identification of early lesions. These patients could be candidates for genetic counseling and genetic testing for better surveillance. And they are candidates for chemoprevention and benefit with risk reduction strategies like mastectomies and salpingo-oophorectomies. So she is the classical example of a BRCA positive, and she's a celebrity who's undergone prophylactic double mastectomy because she was tested positive for BRCA, which reduces her risk of developing breast cancer in future. So as per all the global guidelines, the high-risk individuals need more intense screening modality and a follow-up. And the algorithm of which is starting screening as early as 30 years of age in individuals who have an identified genetic mutation. Thank you.
Thank you for your valuable insights, ma'am. Now, we are privileged to have Dr. Mukta Mahajan, lead in breast and interventional radiology, who will enlighten us on the role of technological advancements in enhancing the accuracy of breast cancer diagnosis. You have our full attention, ma'am.
Thank you so much, Aishwarya, for the kind introduction. So today I have the privilege of developing into a topic that does not only drive my professional passion, but it also strikes a chord with a lot of our patients who are currently battling with advanced breast cancer. Not a day passes when they wonder whether today would have been different if their cancer was diagnosed early. And often the answer is yes. Detection of cancer early does have better treatment outcomes and does have better survival outcomes. So now that you've heard 2 of our surgeons who have given you a good insight on how the cancers behave and how they are treated, I'm going to talk about how they are detected, how they are sampled for confirmation, how they are mapped before surgery, and how they are monitored after a chemotherapy. So we are here to discuss the pivotal role that a technological advancements play in the realm of breast cancer diagnosis. But we must not forget that technology demands expertise and skills, and experienced doctors who deliver that care to the patients. So I'm a breast radiologist, and that means I'm an expert in reading images, medical images of the breast, and that means by using X-rays, ultrasound, MR, as well as CT to image breasts and to find out where are the abnormalities and how to map them for the surgeon before the surgery. I'm also an interventional radiologist, in which means that I use these medical images to accurately locate the abnormality, even when it is hard to see, even when it's hard for your hands to feel, And we are able to sample these abnormalities and produce the sample to pathologists for them to give a confirmatory diagnosis. So as you can see that my medical practice is heavily dependent on machines and technological advances. So what are these technological advances and how they are changing the way we diagnose cancer? So the way we diagnose cancer is not the same how we did 50 years ago, or 40, or 30, or even 10 years ago. We've heard of mammograms since the time the X-rays were discovered. In 1897, the X-rays were used to image chest. By the time this technique was used for breast, it was almost 1930s. By 1950s, we had realized that this X-rays can be used for screening. That means to image breasts of women who don't have any symptoms, but they had the potential to find out breast cancer in its earliest presentation. By 1970s to 1990s, most screening trials were being conducted and were showing us that there was overall mortality reduction if the breast screening program was done in an organized manner. Today we are in 1923. We are using technologies which you can imagine, just imagine how the technology has evolved from 1950 when it comes to telecommunication, when it comes to travel, when it comes to internet, when it comes to connectivity. And the same advance has been seen in mammogram. So the mammogram of 1950s, 1990s is not the same what we do today. So as we all are aware, mammogram is an X-ray, and that's how we image the breast. But today we are able to look at the breast at different depths. It's not a 2D mammogram, but it's called a 3D tomosynthesis, which means that we are able to look at the breast at minute 1 mm thickness slices and see and improve our cancer detection rates. So from a conventional mammogram to a 3D tomosynthesis, our cancer detection rates have gone up 2.2 times. It has also reduced our false positives, which means that the unnecessary test that it would have caused in a woman who actually does not have breast cancer. So it has improved the detection of cancers, and mind you, most of these cancers are invasive cancers. That means that these are the cancers that pose life-threatening risk to a woman in her lifetime. So we have gotten better. We must have heard about dense breasts, and that means that how glandular one's breast is. The problem with breast and the imaging of breast is that all breasts are not the same. They have different architecture, they have different fat to glandular proportion, and also the cancers are notorious. When cancers present as a lump, you're basically looking only at the tip of an iceberg. We know that the cancers can happen in the same breast at multiple sites. It can simultaneously be present in both the breasts. And this, when the woman presents to us, she's only telling us that I have an advanced cancer at a particular location, and then it becomes my job to find out, to map the cancer in the entire breast and provide all this information to the medical oncologist, to the surgical oncologist, so that the right treatment path is chosen for this woman. So this is the commonest question actually we ask all our radiology trainees, that which is the most missed breast cancer? And I would like you to attempt to answer it. So the most missed breast cancer is the second one. The first one that she comes with, and the second one that's hidden in the breast and not apparent to the eyes. It can't be seen and it can't be felt. And that's why we need medical images and advanced medical techniques to diagnose all small cancers and remove them and provide an oncological cure to this patient. There are other imaging techniques as well, for example ultrasound, and it's one of the best techniques we have to image breasts. Mammogram tells me where to look, and I use ultrasound to further evaluate the area of abnormality, and then it also helps me to take a sample of this abnormal area in the breast in a way that's most comfortable to the patient, and it's in a way that's most precise as well. So most of the interventions for breast are done using ultrasound, and that means that we are capable of biopsying lesions or masses which are as small as 3 millimeters in size. So this is the level of precision that we are able to achieve today to give an appropriate diagnosis. So let's spend some time thinking about about 2 or 3 most important factors which are in cancer care. Would it be accurate diagnosis? Yes. Would it be timely diagnosis? Yes. Would it be an appropriate treatment plan? Yes. Is there one individual involved in treating cancer? No, it's a whole team. So would you want to meet this team under one single roof and get your plan from the get-go? Yes. So this is what is the concept of breast clinic is, where you meet all the experts who diagnose and treat breast cancers under one roof, get a plan that's right for you, set the goals of your treatment, and this is the way we see that the patients have the maximum success to the treatment, maximum compliance to the treatment. Moving forward, I'll talk about a few advanced techniques such as breast MRI as well. Now, breast MRI is the most sensitive technique of imaging breasts. It finds us 99% of the cancers. It's not 100%, but it does find 99% of the cancers. So when, after imaging a woman's breast with mammogram and ultrasound, we know that maybe it's going to add more information. We advise a further evaluation with MRI. So MRI is not for all women. It has to be, the test has to be wisely chosen for a certain group of women, but it has a great value in this subset. And it also is very important when we are screening high-risk women or women with familial cancers and high risk of developing, a lifetime risk of developing cancers. Breast MRI is very, very valuable. Now, all these imaging techniques is very important that we are able to use their guidance and sample very small abnormalities in the breast, and hence our accuracy there's always a complete circle. We see something, we biopsy something, we mark something. The pathologist takes all these samples, confirms our suspicion, and then we tell the surgeon that this is what it is at this location. So it's always a full circle. So we leave less things to ambiguity, and that's thanks to the teamwork that we have with all the experts sitting on the dais today. Briefly touching upon the PET-CTs, which is also a very important scan which is used to stage the cancer, which means that it helps us to identify cancer, which is whether it is limited to the breast, whether it has spread to the local lymph nodes, or whether it has gone to the distant sites through blood and metastasized in different organs, and it could be bone or brain or lungs or liver. This is the starting of your cancer treatment, where you stage the cancer and then offer appropriate treatment for your patient. So moving forward, as I spoke briefly about the technologies, the role of technological advancements in improving cancer for breast diagnosis cannot be overstated, and we've just learned that. And it's a powerful tool in our fight against breast cancer. But it's the combination of technology with patient's advocacy, the right for the patient to choose her treatment, to choose her goals of her treatment, and the expert opinion that she receives from cancer management team is truly what empowers the individual. So we form a team, and we make our services available under one roof in order to empower the breast health journey for our patients, marked with compassion, with understanding, and offering her best possible outcomes. I hope this resonates with you on a personal level, and the emphasizing the importance of this technology is something that the radiologists work on constantly through research and through improving their skills and their knowledge through various various medical education events. Now, today as a team, I would like you to say that let's work together to ensure that everyone is facing these challenges, challenges of getting diagnosed with breast cancer, challenges of developing a breast complaint that is causing them a lot of anxiety. Let's make them empowered with information. Let's make them empowered with support in order to make sure that they are on the right path of treatment right from the first step. Thank you.
That was true